In your clinical practice, what is your approach? How do you usually treat patients with, say, these newly diagnosed metastatic higher grade 2 or grade 3 advanced neuroendocrine tumor? Do you do like upfront PRRT for everybody because of the NET2 data?
That's a great question. So a few things to consider. The NET2 enrolled a higher grade population than the NET1. So the Ki-67 was 10 to 55%, but usually in the first line setting. And, it did show progression-free survival benefit, although we don't have overall survival benefit yet. So we'll have to see what that shows. And a few things to consider about PRRT is it's one of these treatments that you can use only a limited number of times in the patient's treatment journey. And so, we have a few great systemic therapy options, and we also have local regional therapy options, but we don't have an infinite number of treatment options. So we have to consider that where it fits in the patient's journey. Our center is a little bit different in that we specialize in surgical debulking, and therefore that usually gets sequenced earlier on in the patient's treatment journey. And so we tend not to use PRRT in the first line setting. I would say probably in my patient population, the patients I would consider is, let's say they have such a high burden of disease that they're going to get in trouble if they don't get some kind of response and they're not a surgical candidate. That probably would be the population I would consider for upfront PRRT.
Is there like a Ki-67 threshold that, say, if it's above this number, that will push you more towards, hey, I probably need to do upfront PRRT rather than give them a shot and wait like in 2 or 3 months or something?
Yeah, I usually consider for the patients who are in that range, 10 to 55% range. If it's like 1%, I probably wouldn't consider it.
How about you, Rob? Do you do upfront PRRT for these higher grade patients?
So it's rare that we'll do upfront PRRT. I think with this disease, we don't have tons of data on the grade 3 patients. In fact, we've got data for PRRT and we've got data for cabozantinib and high dose SSA, I guess now. In reality, sometimes, a grade 3, they're very heterogeneous. So, you may have a grade 3 with a Ki-67 of 22%, but it sort of behaves maybe less like a grade 2, for instance. I was excited with the NET2 data when it came out, a little disappointed that, again, we don't have that overall survival data. And keep in mind, if you treat enough of these patients, you're going to see that MDS and AML, these drugs are not without toxicity. So if we can get away with maybe a less toxic agent by the patient time, I'm usually starting with an SSA on most of these patients. Now the people I would think about for upfront PRRT would be those patients who are G3s, who have a high burden of disease, who are non-functional, and who, like Andy says, who are going to get into trouble if you don't do something. Because the response rates, they were much higher, in NET2 than with PRRT than with an SSA. We know, we don't really expect a response. But, I would tend to save PRRT for afterwards. And especially if we're thinking about surgery, we definitely want to do whatever surgery we want to do prior to our PRRT.
Right. I agree. Interesting. You just mentioned about the high dose SSA data. So yeah, we usually start people with the SSA, right? And then after they progress on the SSA, usually like my traditional approach would be like we move on to get something else like PRRT or everolimus or cabozantinib or chemo, whatever. But we also have data on high dose SSA, like the phase 2 single arm Clarinet Forte trial showed that patients who progress on lanreotide 120 milligram every 4 weeks, they increase the frequency and give lanreotide every 14 days, actually resulting in a median progression-free survival for approximately 8 months or so, like for both GI and pancreatic primary. Is this something that you frequently do or rarely do, like increasing the frequency of SSA when they progress on SSA?
I have done it actually based on that particular trial data. In a minority of my patients, usually in the case of like mild progression, that I feel like I don't want to use up the PRRT just yet.
Right.
So,
like, what has your experience been?
It generally is similar to what the trial data show. It controls the disease for several more months, and then whenever then they progress, then they move on to PRRT or the next line of therapy. But getting insurance coverage can be tricky.
Right, exactly.
Right. Yeah, I guess I'm a little bit different. I think I've done it a handful of times, and the people I've done it with have no other options. So I want to go through all of my proven options. Keep in mind this is a phase 2 trial. So I want to go through all my phase 3 data. So my PRRT, my everolimus, my cabozantinib, my sunitinib if they're pancreas, and or CAPTEM for the right patient. So I want to go through all of that. And if the patient, for whatever reason, gets through all of that or can't tolerate all of that, sometimes we see people with renal dysfunction or severe cytopenias, and I can't give them these other agents, then I'll consider the SSA every 2 weeks. That's no walk in the park either for patients coming to get a treatment every 2 weeks. But yeah, I've used it a few times, but it's not something that I frequently go to.
So in your patient population, it will be very refractory patient who eventually get to increased frequency. What has your experience been regarding the efficacy? Does it even work?
I think you can buy people some time with it, but yeah, it's not changing too much overall.
Right. That's how I feel. For a lot of different reasons, patients very, very symptomatic when they're progressing a tiny little bit, or it's an 86-year-old with tons of comorbidities, absolutely do not want to get anything else, including PRRT. Then a lot of time I would do it. I would say it's not a home run. Sometimes they may slow down the growth by a little bit. But sometimes, if insurance allows it, then it's a relatively easy treatment to give compared to IV chemo, those kind of thing, or some oral targeted treatment. So I do it, but I wouldn't say it's a home run or anything.